evening, everyone. I'm going to talk about an atypical presentation of Foster-Kennedy syndrome due to neurocysticercosis. The triad of ipsilateral optic atrophy with contralateral optic disc edema and ipsilateral anosmia in the presence of a space-occupying lesion in the basofrontal region is termed as Foster-Kennedy syndrome, and in the absence of this lesion is called pseudo-Foster-Kennedy syndrome. Foster-Kennedy syndrome has been reported most commonly due to frontal lobe meningiomas, additionally with craniopharyngiomas and pituitary adenomas, and rarely with neuroblastoma, nasopharyngeal angiofibroma, and plasmacytoma. Here we are presenting a case of ipsilateral optic disc atrophy and contralateral impending disc edema attributed to the presence of an ipsilateral cysticercus granuloma. Our patient was a 13-year-old male who presented to us with history of sudden onset abnormal movements of the left side of body 1 day back. A family member had noticed sudden shaking movement of arm and legs that had lasted for 3 minutes, followed by lethargy afterwards. The past history and family history were not significant. There was no history of visual complaints or fever, chills, night sweats, or history suggestive of motor or sensory deficits. On general examination, the patient was conscious, cooperative, and well-oriented to time, place, and person. The vitals and systemic examination was within normal limits, and neurological examination revealed bilateral dependent reflexes were brisk, plantar reflexes were normal, and cranial nerves and sensory examination were within normal limits. On ocular examination, the vision was 6/6 in both the eyes, near vision was N6. The positive finding was that the patient had RAPD grade 1 in the right eye, and intraocular pressure measured by ORA at 12 p.m. was 12.2 and 17.3 millimeters of mercury. The anterior segment examination was within normal limits. On fundus examination, in the right eye, media was clear, the optic disc shape and size was within normal limits, margins were distinct, there was temporal disc pallor seen, and the temporal and inferior neuroretinal rim thinning was present. In the left eye, media was clear, disc shape and size was normal, the disc was hyperemic with intact margins, and blood vessel tortuosity was present. CDR in the right eye appeared to be around 0.6 and around 0.3 in the left eye. The patient's total leukocyte count was 11,500. Rest hemogram was within normal limits. On CT scan, a 0.8 into 0.9 centimeter ring-enhancing lesion was seen in the right parietal lobe with perifocal edema. On Humphrey 24-2 visual testing, a reduction of the superior visual field was present in the right eye. Optical coherence tomography, RNFL revealed RNFL thinning of superior, inferior, and temporal periphery in the right eye. The vertical CDR was 0.7 in the right eye, 0.5 in the left eye. Cup volume revealed that the cup volume in the left eye was less, that is 0.10, that is there was fullness of the optic disc present. The patient was started on treatment according to the Infectious Disease Society of America. He was started on carbamazepine, prednisolone, albendazole, acetazolamide, and calcium and vitamin B12 complex. So our patient had ipsilateral optic disc pallor with contralateral impending disc edema. Neurocysticercosis, neurological lesions can present as parenchymal cysts more commonly and rarely as ventricular cysts. In India, the most common ocular site is the adnexa. In the Western world, it is posterior segment. The reported cases of visual loss due to neurocysticercosis has been most commonly due to post-papillary edema optic atrophy. Wilbrand and Sanger have reported 1 case of monoocular temporal hemianopia and 2 cases of homonymous hemianopia as well. My conclusion is that ophthalmological examination is necessary in every patient with neurocysticercosis. Along with adnexal and anterior segment examination, a dilated fundoscopy is vital. Foster-Kennedy syndrome, although commonly associated with a frontal lobe lesion, can manifest in atypical forms in such patients. Thank you.
Okay.
Thank you.
Okay, thank you.